let's discuss what is coming down the pike. We've seen earlier this year data from two large trials, randomized phase 3 trials on belantamab mafodotin, an antibody drug conjugate that was originally approved in 2020 for relapsed refractory myeloma after 4 prior lines of therapy based on the DREAM2 trial. It was withdrawn after the confirmatory DREAM3 trial didn't meet its primary endpoint. Now, the DREAM7 and the DREAM8 studies were both positive. So now we will see how our expert panel thinks if it becomes available, how will they use it? Adriana, to probably start off, and we'll go around.
Yeah, definitely tricky. I remember in the early studies, I was very enthusiastic to have a BCMA targeting agent, but as the field's gotten so crowded with the bispecifics specifically, and also with the CAR T, it's getting harder to pick which ones. So I think in a future date, maybe someone who has relapsed after a BCMA, then had an intervening line, and then might be eligible. My pool is definitely getting small, but someone who maybe I don't think would tolerate CRS, or again, coming into the hospital, but would benefit from BCMA, those would be the ones.
Ajay, what's your view on it?
We're a very skewed audience here, right, on the panel, because if you think about US data, only 12% of transplant eligible patients are getting transplanted. So while CAR Ts and bispecifics are amazing, the number of patients particularly that are going to get CAR Ts, I think, is limited. And I think we're all taken aback by DREAM 7 and 8 and how impressive the results were. I don't think we expected this much. And I would say DREAM 7, which compared to DVD, was suggests that the Bella beats the CD38 in a CD38 naive patient, which is quite impressive. Who would have thought that Bella would beat Dara? But the problem is, who's really CD38 naive at first relapse, particularly the transplant ineligible older population? Most of those people, I think we've all adopted Maya type of regimen. In some ways, DREAM 8 is the more interesting one, Bella PD, but problem is they didn't have as many CD38 and Len double refractory patients. So, because that's, again, what I'm interested in for that group. And in the patients that were double refractory, there seemed to be slightly less benefit. But I think the huge plus points of Bella are that it can be done in the community, relatively infrequent dosing. You don't see the same infection signal you see with BCMA bispecifics, which makes it more combinable, right? That's why we see 7 and 8 being so positive. I'm not sure how BCMA bispecifics will be combined because of the neutropenia and infection signal. The therapeutic index there is quite narrow. It is hard to add a second drug. So I think that's Bella's strength. And you don't see a lot of the infectious deaths. So there's a lot of plus points. I think the only con is I always feel like in myeloma, because accelerated approvals are geared towards response rate, we tend to push the dose intensity to just get that response. But then we don't think about what needs to happen afterwards. And I think we need to do a better job. And that's why Project Optimus and other things from the FDA are like, okay, fine, do your RP2D, but what's actually realistic? And I think if it's really going to have a future in the community, we have to stop doing what's essentially phase 1 studies in each patient, right? Like give this high dose, pause, stop, start, just do a prescribed prospective, give 1 or 2 doses, back off, give it a less frequent, and then minimize those eye issues. If they can do that, it's Bella's turf to lose.
Natalie, what about the toxicity, the ocular toxicity that Ajay mentioned? Have you had experience in it when it was on the market before?
We had DREAM2 open, and actually I still have a patient who's in remission 6 years out on single agent belantamab. So I've actually been very happy about this drug in a couple of situations. And one is that we have a few patients on belantamab compassionate use who are older. And so when you can dose these patients quarterly or every 6 months, which is what we're doing in a couple of these cases, without steroids for 30-minute infusion, that's pretty nice. And I think one of the things that I think is probably going to happen in terms of managing the ocular toxicity besides dosing, and longer times between doses is clearly a big deal, but there's probably going to be some practical development of ways to sort of interrogate with the patient what they're experiencing in terms of dry eyes without necessarily having to bring in lots of ophthalmologic or optometry support, because I think that really has put people off and said, boy, that seems so complicated. I don't want to do anything with it. But I think that the DREAM7 data in particular to me was quite striking with high-risk patients. There was a big signal that they did quite well with that group.
The reality of when we talk about CAR T and bispecifics is that there are gigantic swaths of this country that have no access to those things, through Mississippi, Louisiana, through the Southeast, through the plain states. They live hundreds of miles away from places that have clinical trials that do bispecifics or do CAR T. And the only thing you need to deliver belantamab is an eye doctor. And you can find an eye doctor in a mall. And so I had a patient who, just like Dr. Callender said, that had a very long-term response, like a couple of years, or a year response to single agent belantamab. And she went to the eye doctor in the mall. She would go to the eye doctor, go to the mall, some shopping, come with the slip, and then we would treat her. And it was very easy, and it wasn't as resource demanding or financially demanding as a lot of the drugs that we mentioned today. And so I think if you live next to an academic center and you have a great performance status, the things that we said are, or if you can refer a patient and they're eligible, we'd love to have them for CAR T and bispecifics. But if you live in one of these resource limited areas where you don't have a lot of options, signing up for the RIMS program for this drug, finding an eye doctor in the mall, and then using these BCMA therapies in those areas, I think is really important.
Vinod, you have the last word.
If you look at the data, double exposed 30%, single agent response, and here triple class exposed, you have 30% response with belantamab. So clearly it is saying that bela by itself probably not the great drug, but you need to combine it, right? So I think DREAM7 and DREAM8, beautiful example of combination, and this is like first triplet to triplet combination. I think this really give a kudos to the investigator and the sponsor who dared to do that, right? And I think the main issue is the ocular toxicity. If I have a choice of two drugs, I probably won't choose it because of the ocular toxicity. So hopefully we'll know how to use it better. So maybe, less frequent dose, lower dose than what is prescribed. And definitely there is a group of patients, like what Craig said, who won't be able to come here, who won't be able to get bispecific. And those are the definitely patients. And clearly the data showing that, maybe these are the patients, especially the old patients that Ajay said, who had already been exposed to this quad exposed and second line. Cannot come here for CAR T or bispecific. These would be the best patient to get that. But ocular toxicity is still going to be the rate limiting step in my practice. So the number of patients that would get this is smaller.
So Ajay, you kind of hinted in an earlier segment on send the patients to the academic center first to know and avoid giving certain BCMA-based treatments if patients are eligible for other BCMA-directed modalities of therapy. So how would you advise the community when belantamab comes out? You mentioned just now that it is a drug that could be given in the community. So how do you balance those two situations?
I think the theme again is communication, right, between the local doctor and academia, and not inadvertently diminishing a person's benefit from a potential CAR T. So if the decision is pretty clear on the phone, like, look, this is a 85-year-old patient with heart failure, renal failure, and limited performance status, go ahead. And I think they can start the bela locally. But if it's a 75-year-old with no comorbidities, functionally high risk, don't start without speaking to that academic center.
I think that this is going to get even more complicated as in the near future, we'll probably get bispecifics into the second line. And I realize a lot of community doctors are this time not doing the ramp up dose. And it's the academics who are deciding whether to go bispecific versus CAR T, but anticipating that bispecifics will reach second line and will potentially one day even be ramped up in the community. How are you going to navigate that landscape then, Ajay?
So PFS of BCMA bispecifics is around 1 year in heavily treated patients. I think the question is, how will that fare in less heavily treated patients? And I think we have to counterbalance that with also the need to treat till progression, the need for indefinite IVIG support, the need for indefinite therapy. So I think there's differences, even though they're both targeting BCMA. And if a patient is fit, I probably would still do CAR over bispecific. And I think that bigger challenge for me is that I don't know that BCMA combinations are going to be the way to use it in earlier lines of therapy, because we're seeing early data from combination studies. The responses are great, but so are the toxicities, right? You're seeing, for example, when you combine Dara, Len, and a BCMA bispecific, the rates of neutropenia are over 80% grade 3 and even 15% or so febrile neutropenia. And then with a study with Elra plus Dara, there were 15 out of the 30 patients died, of which a lot were due to COVID. I don't think those AEs are acceptable. And I think to really understand how to use BCMA bispecifics, we will need to see the randomized phase 3 studies, because we've had 3 examples in the myeloma, venetoclax, melflufen, and checkpoints, where responses in PFS were great, but you saw diminished OS. And so because of the infection signal, all it takes is a new COVID pandemic, and there goes your OS endpoint with BCMA bispecifics, right? Don't get me wrong, I think they're great. But in some ways, I would say the GPRC bispecific may be easier to move up, although we have to adjust the dose and schedule and combination, but it doesn't have that death signal, which could really affect ability of these products to move earlier.
So dwelling a little further on the sequencing. So Natalie, what do we know about bispecifics and CAR Ts in terms of giving one versus the other first?
Well, I think there's certainly data that probably the sequence that most people are avoiding is a BCMA-directed bispecific immediately followed by a BCMA-targeted CAR T. There's not a ton of data, but there's certainly some fairly troubling data that you really limit your CAR T response maybe to less than a year or much less than a year, depending on what report it is. So I think most people have really tried not to do that. As Adriana said, after you have those CAR T collected and you're manufacturing, then I think you can argue that you could do a number of different things in that space of bridging therapy. And, I know Binod has worked on this a lot. I think a lot of people are turning to talquetamab now for that, because it is very effective in terms of debulking for patients for CAR T. But I think when belantamab comes back, how you sequence that as well. There is a little tiny bit of data that maybe it's not as good before to have that before CAR T, but I think probably the BCMA bispecific followed by the BCMA CAR T is something that most people are avoiding.
Anybody wants to add anything to that? I think there seems to be consensus that try to avoid that sequence. Now, obviously, we've had some discussion on the bispecifics, and in combination, there is a higher risk for infection. Do you guys see that as a monotherapy, bispecifics may have a role in certain populations that CAR Ts are not serving today? Ajay, you mentioned about your concerns about infections.
There are patients who I've had who will never get to CAR T, right? You blink and their disease is progressing. And by the time you were apheresis and manufacture, they'll already be onto a new regimen. And so I think for those rapidly progressing patients is where bispecifics to me really stand out. And also for the patients who have comorbidities, like those, again, the heart failure, renal failure, frail, elderly. Although I said, it's hard to move up to earlier lines with BCMA bispecifics as a monotherapy. I think till we have phase 3, I think maybe TAL can do it earlier. On the flip side, I would say no one with myeloma should die without being offered a bispecific, because pretty much everybody can get them. And the best part is whatever AE you have, you hold the drug, right? And then they recover. That's the beauty of the bispecific. It gives you a little bit more nuanced control. And then I think supportive care is really important with IVIG and then the PAL, emollients, hydration, topical steroids. So at least those AEs are, I think, modifiable, but they definitely should be used in all patients. And the last point I'll make is we're talking about myeloma, but I feel like we're in an inflection point here. There's now, I think last I heard, at least 11 bispecifics approved across multiple malignancies. Where we are today is where we were with monoclonals about 20 years ago, right? Everybody was skittish about rituximab and Dara and infusion-related reactions, and now no one blinks. That's where we're going to be in a few more years. And if community doctors don't get on board with bispecifics, the very patients that need them will not get access, because these are the patients that aren't going to always be able to come to academia for indefinite continuous therapy. So I always ask all community doctors to really do the work and don't let the REMS programs dissuade you from using it. REMS is just that step up period. Otherwise, because unfortunately the myeloma drugs are the ones that have been slapped with those REMS programs, but really important, I think, that community get on board with these.
You know, what I've heard from a lot of community docs is worry about CRS and the resources that a particular practice may have in managing CRS. And one thing that I think really helps, and as part of our practice, is that we've been giving prophylactic tocilizumab to a lot of patients who are pretty high risk of having CRS. They're coming in with vapor disease and have a high tumor burden. And we discuss this with, our pharmacy. And so we give prophylactic toci for some patients on day 0 from their step-up dosing. And that has helped, so, and I think there are multiple studies that have been published about how much it reduces the CRS down to just grade 1s and in the 20 percentiles. And so I think that, if there is a fear of the 70%, grade 1 CRS, you can reduce that down by using prophylactic toci.
So moving on to the last group of drugs that people have been looking forward to, and that is the CELMoDs. I think that we see that CELMoDs have shown activity even in BCMA refractory patients. So Binod, what is your view on CELMoDs?
I think these degraders are the next generation drugs that is gonna impact myeloma quite a bit, down the road. It may not, mezigdomide and iberdomide, and there are a lot of other new degraders coming in the market. And we are seeing responses, as you said, like mezigdomide, we are seeing pretty decent response post BCMA, post GPRC5D space. I think, again, this is probably not a drug that you just want to do as a single agent, that it has to be combined. But if you combine, I think you are seeing decent responses, and you could potentially benefit those patients post T-cell engager therapy and maybe move it early line and as a part of the induction, and then probably even get better responses. So I think definitely I'm very excited about this class of drugs. And this class of drugs is, I think, gonna, as monoclonal antibodies and bispecifics, is gonna go across different cancer spectrum as well. So yeah, I'm so far the data looks pretty promising to me.
So I know, Craig, you're a big proponent of clinical trials, and this is obviously moving forward in clinical trials in the 2nd to 4th line space. What do you think about the future for CELMoDs?
We've had Revlimid as part of our armamentarium and Pomalyst for quite some time. And so I think it's time to have, a new drug, because we know that's effective for the biology of myeloma. I mean, as that full, IMiD CELMoDs has, a proven record. And we need something for patients that are relapsed after some of our newest therapies, because we're working to cure myeloma and we're close to it, but we haven't cured it yet. So we need a really good backup plan when those other drugs fail.
So as far as the CELMoDs go, what is your take, Ajay?
I always felt like these are kind of like iPhone updates. First was Thal, then you get Len, and then Palm. And every time there's a new iPhone, you're like, well, what am I getting exactly for this new one, right? And I've never been convinced that based on the phase 3 data that Palm really does a dramatic job of long-term PFS benefit in Len failures. And I think the preclinical and clinical data suggests that maybe these CELMoDs do have a role. But, in some ways they're just branding. But I do think they have a role. But as we mentioned, 60 to 100% response rate and PFS of 1 to 3 years is the new 20 to 30% for 3 to 4 months. So the days of getting a new drug approved like that, accelerated, have passed. So their only strategy is going to be phase 3 randomized studies. I think it'll be very hard to displace lenalidomide globally because you have long-term use, response, PFS, OS data. And I think clearly the cost will be higher. So I don't think displacing Len will be practical. Palm, I think, can be readily displaced. And I think the PFS data will have to be mature. But then lastly, I would say one of the most unmet needs today is how do you rescue a bispecific failure, right? Because let's say you go to CAR, you have a long treatment-free interval, you can go to bispecific. But then what we know is even switching targets is not enough. So Monumental 1, which led to the approval of TAL, PFS is about 12 months. And same thing for prior CAR T. But if it's prior BCMA bispecific, it's only 4 months. And that means that even switching the target is not enough. And there's T cell exhaustion. And we heard at this year's IMS that one of the ways to deal with that is to combine TAL with either DARA or DARA with POM. And that's where I think maybe Mezi could play a role, right? Like instead of giving a patient a drug that they're already refractory to, why not do TAL plus a low dose of a cell mod? But those data I think are forthcoming, but potentially have that role of really rescuing bispecific failures because these patients have totally beaten up T cells and they need all the help they can get.
Yeah, on that note, I would say our partners at Mount Sinai have published some data showing that iberdomide does alter both innate and adaptive immune responses. And so not only in rescuing, but maybe in partnering with the T cell redirection could be a new role for them, as well as being the oral, right? I think there is the I2D from the IFM showing that iberdomide with ixazomib could provide an all oral agent for being helpful in getting access.
So starting to wrap up, we'll go around again and say, and I will start with Binod. So Binod, what are your key takeaways for where we are headed in the second to third line, fourth line space for our audience?
Fourth line space, we are very lucky again with all this new development. 4 years ago, fourth line space, it used to be either clinical trial or recycling of the drugs, right? Now we have so many options, which is already approved. So that is exciting. Having said that, there is still unmet need for patients because they do progress, they do relapse. And so I think we need to look for the newer agents, newer targets, and which already is happening. So I think overall, I think it's very exciting times, for patients and both for the physicians to treat myeloma. There is still a lot of understanding needs to be done in disease biology and how to kind of really intervene early on so that you can get the long-term durable responses. So yeah, I would say that is the...
Adriana?
Yeah, similar, we'll have data on how patients have tolerated and responded to multiple agents. And so that can inform, and remembering that we do have many options. Again, I know I, for one, am very enthusiastic on the CAR T side of things, but I'm very aware that that's in New York City where we have 5 centers in close proximity. So remembering that not only there is the biology of myeloma, the comorbidities of the patient, but the bigger psychosocial support all can be taken into consideration to really personalize the choice for the patient.
Natalie?
I think, there's a couple of practical things. For people who've never had an anti-CD38 antibody at the time they're relapsing, and they're still around, of course, that would be a choice. Carfilzomib remains a very active drug. And I think it is possible to give people carfilzomib well into their 70s and even 80s at 56 milligrams a week dosing is pretty well tolerated. But again, I think we have said this before, but we would all be very happy to have a conversation about what would be appropriate later line therapy. But those are just a couple of things to always keep in mind.
Greg?
Yeah, I'm really, the one thing that I keep kind of worrying about, what keeps me up at night, is access and the disparities that are out there. And what I'm really excited about is not only, is the research working on therapies where people have access and really, again, reaching for that cure of myeloma, but also that there's research being done for areas that may be resource poor and don't have, access to the academic centers, which I think is really key, that we make sure that we enroll patients that we haven't previously enrolled in clinical trials. We need to enroll more older and elderly patients on clinical trials. We need to enroll more, people of different races, ethnicities, and genders on clinical trials, because as I have mentioned 1,000 times before, the only way we can cure myeloma is to make sure we cure it for everyone, which includes making sure that we do research and cure myeloma people in resource-rich areas, but also keeping our eye on resource-poor areas.
You have the last word, Ajay.
I think we've been highlighting the patient and disease factors considerations in therapy, but it's like a math question. Now we have a treatment, and it's like drinking from a fire hydrant. Every day there's a new New England Journal paper on myeloma, and I can't imagine being a community doctor trying to process that patient disease and treatment factors. Many of us on this panel remember the days of deletion 13q being high risk. No one cares anymore, right? And where we are now is on that precipice. We have really exciting data recently that TAL has shown that potentially PFS is the same in high risk as standard risk. how plus different agents have been shown to improve upon prior bispecific. We saw double bispecific potentially overcoming EMD. So I would just highlight the need for clinical trials in this heavily treated space, exciting combinations, not only with bispecifics, but even combination CARs, right? Like dual antigen CARs, which maybe aren't seeing the neurotox signal. So I think we really need to keep going with the pace of research, and these unmet needs are only going to be solved with clinical trials.
Thank you. This has been a great discussion. We want to thank again Sanofi and Janssen for their generous grant support and Cancer Communicator for the program management and development of these activities. Thank you all for taking the time out of your busy lives to have this discussion and really break down how to manage patients in early relapse. We have some very good tools in our toolbox, and there's a lot of excitement about what's coming down the road. Enjoy the rest of your day.